Hey everyone, today I'm going to be presenting on global capacity for implementing the 8 practical steps, a framework by the WHO and UNICEF to reach universal access to WaSH and healthcare facilities. So the 8 practical steps are a WHO and UNICEF guideline that's designed to help countries reach universal access to WaSH and healthcare facilities. It's focused on broad national action. There are some sub-national action steps within those, but for the most part, its target audience is national health policymakers, district managers, implementers, and other folks that are acting at a fairly high level across the country. So, as the name would imply, the 8 practical steps are 8 steps. They're listed here, and countries are supposed to follow these steps largely in order, although there is some flexibility. So first, conducting situational analysis and assessment. So these are things like collecting baseline data on conditions of a particular country, and situation assessment, looking at some of the enablers and barriers to implementing services. Then setting targets and defining costed roadmaps. Establishing national standards and accountability mechanisms. Then it moves to an action phase, so improving and maintaining infrastructure, monitoring and reviewing data associated with the rollout of that infrastructure and other earlier steps, developing the health workforce, and then these later steps for engaging communities and conducting operational research. And the 8 practical steps are these 8 actions that countries are supposed to go through as part of their journey to reach universal access. So the 8 practical steps are a broad roadmap for action, but there's relatively little specific guidance on how to accomplish each step. So for example, the step to develop a costed roadmap largely just says countries should develop a costed roadmap informed by cost data that outlines budgets. And there's relatively little guidelines on how that should actually occur. The WHO and UNICEF collects country-reported, so self-reported data, and it's available on washnhcf.org. If that's a website that you visited, I recommend that you go there. You can see these data. It's just an excerpt here. And this country-reported data indicates that most countries have started at least one of the 8 practical steps, but very few, if not none, have actually finished all of the 8 steps or even made kind of appreciable progress towards a majority of the steps. And furthermore, there's little systematic evaluation of readiness to complete the steps or understanding the barriers and drivers that might facilitate countries to making progress on these 8 steps. So that's exactly what we looked at. We set out to systematically evaluate stakeholders' readiness to conduct each of the 8 practical steps, and then to document perceived capacity development needs to increase readiness to perform the 8 practical steps. We did this through a qualitative study. We applied a theory from implementation science called the theory of organizational readiness for change, which hypothesizes a set of specific determinants that predict readiness to implement a program or take national action on a specific issue. These are organizational level determinants, so it's things like attitudes for change across an organization, resource availability, communications networks within an organization. Notably, these aren't individual level change determinants, so they're not things like knowledge about an issue. They're very much kind of higher level organizational determinants. And we looked at these through qualitative interviews with WaSH experts, typically at a kind of a national or a senior level, policymakers, senior managers, etc. Our study participants, we had 43 that were primarily concentrated in sub-Saharan Africa and South and Southeast Asia. You'll notice a few high-income country folks. These were typical global or regional experts that supported implementation in low and middle-income countries, so really focused on a low-resource country context here. Most of our sample was non-governmental and multilateral organizations, although we did have representation from government, as well as academics, the private sector. You'll notice here, most of our sample had more than a decade of experience, so we're really talking to people that have been kind of deeply embedded within the WaSH sector and the WaSH and healthcare facility space for a long period of time. So I'll get into results now. The most ready steps where people felt that they really were prepared and had engaged in meaningful action on these steps were step 1 for conducting baseline assessments of WaSH conditions, step 3 for setting targets, step 4 for improving infrastructure, and step 6 for strengthening the health workforce. We found the least readiness for step 2, defining costed roadmaps, engaging communities, and then operational research. Step 5 falls somewhere in the middle, so I'm not going to cover all of these today, but I'll go through some highlights. So if we look at the most ready steps, again, it's these 4 down the side here. Things that determined readiness of these were, unsurprisingly, first and foremost, available resources. But when I say available resources, I'm not just talking about money here. I'm talking about kind of the full spectrum of finances, knowledge, human resources, etc. And what we see driving this trend particularly is availability of monitoring tools, such as WaSH-Fit, the JMP indicators, that are in particular driving this readiness for step 1, baseline assessment, as well as some of the later steps for setting targets in terms of understanding what the current status is to be able to set achievable targets, and targeting needs to improve infrastructure. The other things we see that support readiness in terms of resources are availability of national and international standards and guidelines. So for example, we had a large number of people saying that they had turned to guidelines from the WHO for hand hygiene or other WaSH services, and that they had simply adapted those for their own national purposes. And then we also found people relying on prepackaged training criteria. So for example, things like Teach Clean or various hand hygiene resources that are available within the medical sector. I will note that for these prepackaged training curricula, we see greatest readiness on things that are being adopted from the medical sector. So conventionally, that's hand hygiene first and foremost, and then to a lesser extent, cleaning and waste management. We see very little prepackaged training curricula around water and sanitation specifically. Other things that are driving readiness, we found fairly universal, strong cooperation and positive attitudes towards change. Now, partly this is because we're interviewing people in the WaSH sector about whether or not they believe WaSH is important. So unsurprisingly, we're finding people agreeing that WaSH is important, but also people perceiving that all of their colleagues around them in other organizations, in the ministry, really feeling like there's a strong collective spirit and prioritization of WaSH in healthcare facilities as a key issue that warrants urgent attention. And also a willingness to actually take action towards that. So it's not just people saying, yes, this is a really critical issue, I wish someone would solve it, but saying, yes, this is a really critical issue, my organization or my agency within the government is stepping up and taking these specific actions to solve this problem. So strong willingness to change, but also signals of people acting and willing to step up and take responsibility for that action. And then finally, we found technical support and partnerships, strong presence of WHO, UNICEF, as well as partnerships from other international NGOs, universities, and others who were supporting action, particularly in these areas, largely around improving infrastructure, but to a lesser extent, some of these other things. When we look at capacity development for these 4 steps, the biggest thing we found was a need for contextualization of some of the existing tools and guidelines. So notably, this was contextualization across facility types. So noting that a small rural clinic is going to have very different needs from a large urban hospital, and these monitoring tools that we have are kind of billed as one size fits all, but realistically probably are not. And then aligning those tools with national standards and guidelines, and then offering an expanded set of languages in those tools. The other big need that we found is a need for situation analysis that goes beyond simply baseline conditions. So looking at the policy environment, the finance environment, and other things beyond service level assessments that allow effective service delivery. And then finally, training guidelines and other resources for post-construction support and operations and maintenance. We're doing a pretty good job implementing infrastructure. There's much less attention being paid to what happens to that infrastructure in the 3 to 5 years post-implementation. Looking at the steps that have less readiness, as a reminder, these are steps for defining a costed roadmap, engaging communities, and operational research. What we see in terms of readiness determinants, or in this case, readiness barriers, are a lack of data, tools, and templates. We had a lot of people looking at the eight practical steps and saying, okay, this is a good idea. We want to develop costed roadmaps. We recognize that this is a thing that we should do. How do we do it? I've never developed a costed roadmap before. I'm not an economist. I'm not a finance person. I don't know how to do this. And then relatively few resources available in terms of guidelines or templates or other kind of plug-and-play resources where people can pick up a tool off the shelf that will help them along this journey, in particular to define a costed roadmap. The other thing we see is relatively little published evidence on process and qualitative steps. What we see in the literature, both in terms of published academic literature, but also gray literature and other kind of process about information that's available online and through other platforms, is a lot of baseline condition assessments and a lot of program evaluations. What we see very little of is process information and process evaluations on how to go about defining targets, how to go about developing a costed roadmap, and how to go about many of these other steps that are beyond just implement infrastructure. These steps were perceived as less urgent. There was a strong sense of action towards, okay, we have to implement infrastructure, we have to make progress on solving this problem, and progress was typically perceived as building things, doing a training, and engaging communities and conducting operational research were seen as less important towards contributing towards progress on solving these issues. And so there was a strong sense of, okay, we're going to implement first, and once we've made progress in solving the problem, then we're going to figure out how to do engagement and learning, but that's a problem for the future. We're not ready to do that just yet. And then finally, relatively low confidence in skills and abilities, in particular to conduct operational research. So people had a fairly high readiness or sense of their own abilities to do some of the other steps, but really felt like they were kind of lost in terms of how to do some of these later steps. So for capacity development needs, again, a request for guidelines, examples, and templates on how to conduct some of these more process-focused steps. A need for resources, specifically earmarked resources for engaging communities in operational research, which were often kind of afterthoughts, so being sure that that's baked into the process initially. And then training and partnerships on how to actually do these later steps of engaging communities and conducting operational research. So I'll close with recommendations here in terms of what we see as the greatest needs that can be more immediately filled to support countries to progress towards these 8 practical steps. The first is tailoring existing resources, particularly in terms of that initial step for baseline assessments, as well as some of the guidelines around implementation to different facility types and contexts, rather than adopting a one-size-fits-all approach. Developing guidelines and templates beyond just implementation and monitoring. So thinking about how we might guide the process and measure the process beyond simply implementing infrastructure. Supporting operational research alongside implementation, and thinking about how we can capitalize on the lessons learned alongside rollout, as opposed to waiting until we finished and then reflecting back. And then finally, generating evidence on process and not just impacts, and importantly, making it publicly available. Certainly there's a huge amount of organizational learning that's happening around processes, but it rarely makes it to a public platform where other people can actually view it. And I'll put up my summary slide here and just close to say there's a really great enthusiasm and cooperative spirit towards strengthening progress and reaching universal access. So it's a great level of optimism to take away. That can be enhanced by tools and guidelines that are available and helping to support readiness, but are not yet comprehensive, and recognizing that our emphasis on rapid action sometimes compromises strategic planning and maybe misses a few opportunities for learning and improvement. I'll recognize our graduate student, Carolee Sadler, who contributed substantially to this work, and then Ryan Kronk as well, who supported this project.
Questions?
Want me to go first? I have a few. Catch up on that afterwards too. I think a couple of things I'd be interested in is you talked about people having more than 10 years experience in WaSH and healthcare facilities, and it hasn't been a field that's really been around that long, so something more, are they coming more from the health or the WaSH side?
That's a good question. I think we have that in our data, but I don't recall offhand. Sorry.
And I wondered if you could reflect a bit on the usefulness of the theoretical framework, the theory of organizational readiness for change, as to how useful you found that, what the limitations were within this application.
Yeah, it's a good question. Myself included, people are advocates for implementation science in WaSH. I think it's a useful approach in terms of structuring things and ensuring you're not missing kind of broad areas of, oh, we didn't think about training at all. Let's be sure that we capture that. I am less of a convert in terms of applying the precise definitions of how a specific construct comes from the literature. And so some flexibility to take those frameworks and recognize, okay, this is a theory that comes from the medical sector. There's specific issues around infrastructure engineering that apply in WaSH but don't necessarily apply in the same way in the medical structure. So I would advocate for the broad organizing categories of the theory being particularly useful, and then tailoring the specific definitions to be more fit for purpose.
Thanks, Darcy. I'm just curious, especially on the 8 practical steps and the ones that are the harder to reach ones, especially things that are like operational research. There were things when the 8 practical steps were proposed or put forward, these were aspirational steps that I just wondered, the architects that put those forward, their idea of operational research, how do they define it to how the countries themselves perceive what it's the intended objective? I mean, that's the whole operational definition of, which means if we set a goal for someone that other countries actually have the capacity to do so, or do we understand what it's meant by it?
Yeah, that's a great point. And I do think there is, to some extent, the language becomes a barrier around operational research. Sounds very academic. I think many organizations that perceive operational research to be out of reach for them are doing it, they just call it something else. So it may be, they may just call it organizational learning, or monitoring, evaluation, and learning. And that that perception of, oh, operational research is a very academic thing, we don't do that, is, I would suspect, a barrier to actually disseminating that information in a more meaningful way and saying, no, the learnings that you are developing are hugely valuable. Let's share those with other people, and let's not frame this as something that is exclusively done by academics.
So just as a follow-on question then, does it come up in your interviews or with the data that people's perception that they are not able to deliver on that is because of this sort of mismatch understanding of what operational research is, and how would you then report yourself, because these 8 practical steps are self-reporting, that you have attained that? Is there a definition of when operational research is achieved?
Yeah, it's an interesting question, and one that pushes, I think, the bounds of the data set that we have. I would say that's probably a reasonable hypothesis, but we're doing kind of hour-long interviews that are covering 8 specific steps, so it's not something we looked at in a huge amount of detail.
Thank you.
Any other questions? All right, let's give Darcy another round of applause. And up next we have Ann Ong from University of Oxford.
Thanks, Ryan, and thank you, the organizers, for giving us this opportunity for me to sort of present this collaborative research. I sort of frame it as an action research that has born sort of serendipitously through my time working in my master's, and I've sort of giving a bit of a contextualization and positionality. A lot of what framed the original question comes from my prior sort of career as a clinician. So I then come to the WaSH space with a clinical lens. So that might sort of come across and why I'm asking these questions that may not have been sort of being as overt in the sort of WaSH in healthcare narrative this far. So this work is very much, I'll call it, an action research that's come about with a collaboration of academics, development partner in the case of UNICEF, and we work very closely with the government of Bangladesh because we had these questions on, we tried to generate context, relevant evidence to inform action. So I hope by the end of the 15 minutes, you would sort of, 12 minutes, be able to sort of convince you that the water for healthcare facilities is more than just drinking, and that currently are we, in a way that we have been framing water safety, water quality in this space, are we actually missing the sort of risk to patients as a consequence? So we've heard over the last 3 days that WaSH crosscuts all the sort of ultimate goal in what we're doing in healthcare is to ensure and protect and improve health and protect well-being. So it's sort of, you see WaSH sort of in light touches being mentioned across these quality of health care, universal health coverage, IPC. It all goes, and now these days antimicrobial resistance is now being a real topical sort of selling point for why WaSH is important. But also drilling down to the hard science, we still know that nosocomial infection, or HAI, healthcare-associated infection, is still the leading cause of preventable harm to patients. And unfortunately, the burden of nosocomial infection is disproportionately seen in lower to middle income countries. And there are many factors, in addition to the sort of inadequacies in WaSH services. But what we do know is that currently the data for good quality, robust data on epidemiology, on nosocomial infections in the LMICs is still weak. I'll come to that, to why it's important and how it sort of shapes our thinking. And in Bangladesh, in this case, we can have incidents reported up to about 30% of patients have nosocomial infections. And newborn and maternal health deaths are still up to a quarter attributed to nosocomial infections. So despite that, we talk about how important water is for infection prevention control, but we don't talk a lot about the fact that water paradoxically can also become a cause of harm. There's actually enough literature out there, but I just don't hear that talked about a lot in the WaSH space. And unfortunately, a lot of these literature comes from high-income country setting. And so speaking from personal experience, when I used to work in the UK, we had an outbreak due to plumbing contamination of our plumbing, and we introduced it to our intensive care patients. And the reason we could pick it up was because we had a robust clinical and diagnostic services to say, hang on, there's an unusual bacteria, environmental bacteria in this case, which is Acinetobacter, and we had introduced it to our patients through the bronchoscope when we're doing interventions for patients. And the risk is disproportionately seen in the most vulnerable. So people who are either got impaired immunity, newborns, intensive care, got interventions. So that's what I want to highlight, that currently, there's this current recommendations, institutional recommendations from WHO and CDC, is that we should work closely with our infectious disease specialists, and we initiate an environmental investigation when we have clinical data to say there's an outbreak occurred. But working in a low-income setting, we don't have that robust surveillance and diagnostics to trigger. So this is sort of like cart before the horse. By the time we actually have these sort of recurrent infections, we don't actually know it's come from the environment. So the last thing to say is that it's more than just drinking. So the pathogens in the water can be seeded through, either because you're through aerosols, through droplets, through contamination of the equipment, and through actually washing the wounds directly. So first thing, healthcare facilities, we should do no harm. So these are sort of very overlooking controllable sources of infections. So where we are coming now back to our research is that in the JMP, we chatted about the WaSH in healthcare facility. JMP has a set of service level indicators. But if you look at it since its iteration in 2016, a lot of these parameters had been sort of co-opted from the household setting. So it's very much still infrastructure focused. So what you're seeing is that there's an emphasis on access from improved sources, water on premise from improved sources, and the monitoring of drinking water. So I'm working very closely with the Bangladesh government now to try and move forward with its national strategy. They do have a national WaSH standards and implementation guidelines, and so like what Darcy just said before, these things are borrowed straight across from the WHO guidelines, which also then informs the JMP. So therefore, they are following very much similarly, just infrastructure access monitoring, and at the moment, drinking water monitoring, which I'll come to the next point, we don't do. So we're just giving a bit of country context in case for audience were not familiar with Bangladesh, where we are in Bangladesh. It's a country that has 171 million populace, and currently there are 254 government hospitals that are responsible for providing emergency and specialist care to the most vulnerable, the poor and the rural poor. So there's about up to 30% of that population will be seeking care in these facilities. There's known to be overcrowded. Poor environmental hygiene is routinely described in lots of literature that's been published due to various reasons: poor maintenance, poor cleaning, and so suboptimal waste management. So just the photos on the right to show that you're overcrowding to the point that you're going to have 3 or 4 babies sharing one incubator. So we have data. This is, I know it says the National Hygiene Survey 2018, but these data was used to inform the most recent JMP reporting as well. So you see that there's a disparity between government and non-government facilities, and currently the overall sort of water infrastructure coverage comes at about 77%, for 80% for improved access. But we don't actually have any data on the water quality or nosocomial infections. So I have no epidemiology understanding how much is it due to environmental pathogens. So this is one of the pictures I've got from when I did my first field trip. And I see carers are actually washing the wounds of the patients with water they've just collected straight out of the tap. So unlike high-income countries, we'll say you need to use sterile water. You use what you have available. So my question when I saw that photo was, how safe is the water? So that's how it sort of then born this project over the last 3 years. It's sort of taken a while for us to sort of generate the empirical evidence. So we set out to try and understand what is the quality of water services for healthcare facilities. And we had 3 objectives. And one is to examine the quality of water services as assessed by the JMP, WaSH and Healthcare Indicators, and drawing on the empirical literature that I've sort of talked about opportunistic nosocomial pathogens in water systems. I want to know, are they there in the water systems? So then we wanted to compare how does E. coli, which is the drinking water quality indicator for health for drinking, how does that perform as a healthcare indicator, safe water for healthcare use? And lastly, as part of my sort of more extensive work, is I wanted to map the environmental and infrastructural, the multidimensional risk that's going to cause and that may impact on water quality. So in this cross-sectional study, it started out as a pilot because it was really much from that one observation. We then tested the hypothesis, what's the water like? So we did this over the first pilot over COVID. And that time we had about 14 healthcare facilities, and then based on those results, we then moved on to do a second phase of seasonal testing. So all the facilities that were recruited had established basic water services by the JMP indicator. And we specifically, because I was interested to look at the patients who are most likely to be susceptible to nosocomial infections from waterborne a nosocomial infection at risk, then you're looking at patients who are going to have interventions done to them, surgery, newborns, sick newborns, and mums that are coming into the hospitals to give birth. So that's, as you can see on the map, we actually went countrywide. So we did a conversion mixed method approach to try and capture those enough sort of really sort of holistic understanding. So it involved a sanitary inspection of the water systems from source to the point of use, and a systematic and seasonal sampling of the water, and as well as a survey to try and capture sort of those operational and maintenance practices and capacity to manage the WaSH services. So just to give you a bit of a taster of what I meant by sanitary inspection. So I sort of took a lot of inspiration from the water safety plan approach, and then entailed sort of doing a really sort of detailed water system description and walkthrough. So I certainly now became from a clinician to a water engineer, so I started to learn how to sort of draw out schematics, and I found it was actually very useful because we wanted to know, especially in hospitals, and we are now in this phase of talking about climate resilience, you need to have storage. So you need to then map where does the source go to in the case of Bangladesh, there's a lot of underground reservoir because the whole emphasis is about supply. So then you needed to have a huge reservoir on the underground space before you go up to the overhead tank, and then we follow down to the tap. And so this is the special care newborn unit, which looks at the most sickest, vulnerable newborns. And so then at every point, we then mapped and identified any infrastructural and behavioral hazards and risks. So concurrently, then we actually sampled the water whilst I sort of walked through the system. So where there was groundwater that we were accessible, we took groundwater for that. If it wasn't, then we took a proxy groundwater from hand pumps. There are lots of sort of hand pumps in the facility, so I'll talk about that a little bit later. And then the storage systems, then going on to the taps, and then drinking water as well, because we want to see how does the drinking water fare against the water for use. And so patients that were looked after had the highest risk, so in labor room, operating theatre, and SCANU were then considered high-risk clinical areas. And outpatient clinics and the general wards were what I then designated as low risk. So just not going to go too much about the microbiology side, but I had to sort of funnel down because in reality, cost is a major determinant in how many bacteria I can test for. So I did the funneling by mapping out what are the AMR priority, pathogen priority lists, infectious diarrhea, because that's still a very important issue in public health issue for Bangladesh, and then the nosocomial pathogens that are implicated in South Asia. And from that, we sort of funneled down, initially 10 pathogens in the pilot phase, and from that pilot phase, I worked out which were the frequent, the pathogens that were frequently occurring, and then we brought that forward to then be shortlisted for the seasonal testing. So the final hit list of 6 had E. coli, Acinetobacter, Legionella. So Legionella is a pathogen, priority pathogen for plumbing system, and Pseudomonas, Klebsiella, and Staphylococcus aureus. So this, I'm just now going to go straight on to the results. So just giving you a taste, I'm trying to take you through like a story on what I see on the ground. So sanitary inspection, this is the scene on what you see. So you have what we call, these would be considered improved water source because they come from deep tube wells and they are on premise. But if you look at the location of the tube wells, it's next to a drain, it's uncovered, it's not protected. And you can see that there are all the medical waste littered and adjacent to it. So they are often exposed to environmental contaminants. They are prone to lots of weathering. So you're going to get a lot of infrastructure wear and tear very quickly. So next on, contamination pathways are frequently seen because you find that a lot of the infrastructure due to weathering are either defective. You see cracks on the cover over on the far right corner, and then you see a dog just lying over adjacent on top of the underground reservoir. And then you have cracks to where the inlet outlets of the pipes are going into. So these are where there are also a lot of footfall. So a lot of these systems are unprotected. And also it's quite common to see that the overhead tanks are uncovered. So the other elements we saw was that there were contamination risks due to either gaps in knowledge, like what I'm showing in the picture in the top right-hand corner is what I call an aerator. It's like a mechanical sort of plug that you put at the end of your tap. And you ask, when we go around doing the sampling, most of the staff are surprised that this little thing comes off. And it's known in lots of published literature that it's coated with biofilm. So it's actually, but the staff are unaware that this is part of the fixture that potentially becomes another source of contamination. But then again, the one on the bottom right corner, that's an overhead tank that I typically see because it has never been maintained. When you ask the staff, does anyone walk on top of their roof? and you ask the healthcare managers, they are unaware. So all we are currently, they can tell you details about supply, disruption, but what's the condition of the overhead tank, those things are missing. So water systems have a very diverse setup. You have ranges from deep tube wells to a really sophisticated reverse osmosis system, to a tank that's sort of collecting the sort of pipe system, water pipe from the hospital network into a storage tank with a tap, or a tap that's connected to a wall. So these are the range of drinking water systems we would see, and by JMP definition, they all are improved. So this is just to show that what our team was doing at the time when I inspect, they'll collect the water. So you can see the one in the middle, the water is orange in color because it's full of rust. So now we'll get to the sort of crunch. So what do we see? So you've seen the condition. So you shouldn't be surprised when I present the microbiology results. This is the reality. So just walking from, if you've gone through that sort of journey with me, from source to tap, so from left to right. So from the ground, the water at the moment, they are about 78%, and this is for the presence or absence of E. coli. So we are using the water quality risk as defined by WHO for E. coli detection. And so, but as you go down the chain, you see a big drop in the water quality, that by the time only 36% of the water that comes out of the tap remains safe. So you see that if we were only to measure drinking water, you're going to then get lulled into this sense of security that you actually have safe water overall, but the water that's actually for clinical use is only 36% is free from E. coli. So there's a large disparity along the water system. And people have always asked me, what about the drinking water? Do you see differences regards to the technology influencing it? Currently, the sample size is pretty small, and because water quality, as you can see, 80% are free from E. coli. We have very few E. coli presence. Therefore, there's no statistical significance. But the signal is that water that's supplied through the hospital network, if you've seen the hospital network, you shouldn't be surprised are the ones that are going to be contaminated as well. Whilst water that comes directly through the hand pumps and ones that are supplied by its own water line with very minimal sort of distance in between are the ones that are relatively safer. So this is just a Sankey diagram just to show that this big precipitous decline, that water that started out safe, the biggest drop in contamination occurs at the point of storage. So we have only 45% of the water that started out as safe, means without E. coli in the water, remaining safe by the time it comes out of the tap. No surprises that water that heavily contaminated downstream will have corresponding upstream high contaminations at the storage. So what about all the other cousins and friends that might be coexisting? There's a high recovery of those. And it's quite worrying because you had up to 83% recovery of Acinetobacter. Now, I don't have good national data to correlate how much does Acinetobacter feature in nosocomial infections in the epidemiology. But there are data from South Asia and India, and this is one paper that I when I read it, I think, gosh, this is one about newborn sepsis. And what's different to other sort of newborn sepsis in high-income country, we get newborn sepsis often attributed to bacteria that comes from the maternal sort of flora because of the process of birthing. But in this study, it showed that the epidemiology were the causative pathogens causing newborn sepsis for babies born in hospitals come from environmental pathogens primarily. So there are high incidence of Acinetobacter, same bacteria that was most frequently detected in our study, Klebsiella as well, and E. coli. So now putting it into context, this is what I've been trying to do is synthesizing it. How do we then measure the adequacy of water service for use in high-risk clinical areas? When you're assessing it by GMP service indicator, we all meet 100%. But then when you start to detect scrutinize the adequacy of the water quality by detection of critical waterborne pathogens, there are guidelines out there. And there are three pathogens that have sort of global guidelines, and it all varies from jurisdiction to jurisdiction. Number one, no E. coli. If we account for that, we already lost 48%. Then we go to the next step. Some countries have guidance on Pseudomonas aeruginosa, and that is, if you start accounting for that, you drop another 31%. We did get Legionella detected in our water sample, and there's a threshold in recommendation. So when I apply the threshold of less than 100, then I lose another 2%. So finally, only 19% of the water that is for high-risk clinical areas. So just to remind yourselves again, operating theater, labor room, newborn unit, dialysis, these are the ones that are free from all three pathogens. So if I was in the UK, I would have to meet all those three stringent criteria. So this slide is trying to show what's the limitation of using E. coli as a predictor for safe water for use. The problem is because you see the disproportionate higher recovery of the other pathogens. So even in the absence of E. coli, I'm still getting the other pathogens being present. So in the absence of so we talk about negative predictive value. The likelihood of a negative E. coli test telling me that it's safe from other pathogens is poor, unless you're looking at something like Klebsiella pneumoniae. Not surprising, because it's also another sort of we call a fecal contaminant, fecal originated pathogen. So lastly, I think this is my last two slides. I can't help it because it's just the nature of the work, and also now we're trying to build a real advocacy case. The bacteria that are recovered are full of multi-drug resistance, and that shouldn't be a shock. So if I had a chat to someone yesterday about the E. coli, literally there's no sensitive, none of the E. coli is sensitive to any antibiotic. But if your source of contamination is from the hospitals where the patients are already primed with antibiotics, you shouldn't be surprised that the resistance in the bacteria that's contaminating the water is going to be really high. So the last thing is just to add in on seasonality. I've started to do some seasonality testing. I'm interested, so there's implication to how seasonality of the water quality is for us when it comes to policy and planning. Because if I was to try and do a water system maintenance, based on my seasonality study, I would say to the hospital, do it during the cold season, because one, is much easier for you have to work on top of the roof. But two is that there's less bacterial burden. So if you have to do a lot of purging, cleaning, you're going to minimize accidental exposure to the patients from bacterial spread. And then timing of surveillance is critical. If you're going to do all your water quality sampling during winter or cold season, you're going to get a false representation of better results. And then the last thing is that water storage needs to be proactively managed during the changing, so as we are hotting up globally. So this is my last slide. So just in a sort of bringing it all together, there's a strong interdependency of hospital ecosystem, WaSH operational capacity, and water safety. So I sort of try bringing it together in this sort of water safety. You can sort of look at it as a triangle. All three components need to be looked into. So if you're only just monitoring drinking water, you actually overlook the risk of waterborne infections from other opportunistic pathogens. And water quality deteriorated from the source to the final point of use. So that again highlights the importance of regular O&M, water safety planning, and this needs to be institutionalized within the sort of health system management, so healthcare facility management. And currently, where Darcy sort of was before me about this whole discussion about water infrastructure investment and construction seems to be what is dominating the conversation. We don't put enough emphasis that it needs to be matched with a correct sort of life course O&M to maintain those systems. So unless you're not safeguarding the water quality, you're sort of really just undermining your whole effort about the IPC. We keep saying water is good for IPC, but if your water is full of bacteria, I'm not quite certain about that anymore. And seasonality or water quality is sort of highlighted again. Those are factors to be factored in your planning and monitoring. So lastly, just a plug on our work, and currently this has all been put together for a manuscript, but we do have a poster that sort of synthesizes the presentation in a one page. So I would like to acknowledge and thank all the different partners and the funders who, without their support, this would not have happened. Thank you.
Real quick, could you just go back to the QR code, please?
I apologize. So there's quite a lot to cover, so I'm sort of trying to come through in a breakneck speed.
Yeah, that's fine.
Thanks so much for that great presentation. It's like a comment or a question. Did you try to look at maybe the correlation between the organisms you isolated in the water versus the organisms isolated from patients at that hospital?
I wish I could. And then it comes back down to that whole discussion point that currently Bangladesh doesn't have the capacity for that data. We don't have those clinical data on nosocomial infections. We have we have people who are clinically diagnosed, but when it comes to microbiology to confirm and correlating it, no, there isn't. So I don't have even historical data to go back to. And so what you find is often any sort of reported data these days are often done as either what we call a surveillance, random surveillance, or part of studies. So there's no good government sort of, the current capacity for data is poor, so no. So in brief, I don't have those data to correlate, which is why I sort of mentioned the Indian paper, just to sort of highlight sort of those coincidentals or observation I'm seeing.
Hi, yeah, great presentation, thank you. Did you find that there was like awareness at these facilities among patients or workers about the water, and did people try and like take actions to find alternate sources, or was it typically like perceived as safe?
You're correct. It's quite interesting. Until I started broaching this work in the last 3 years, I'm sort of quite answering your question. There still is that idea that because it came from an improved source, it's safe. And I was quite surprised that until I started taking the team through with me and people looked at the condition, and until we started bringing the microbiology result to come and show that it actually is no longer safe, and I'm actually needing to sensitize WaSH colleagues to that as well. So there's still this perception that improved source equals to safe, even if it goes through this sort of convoluted network. So, because the emphasis is all about supply. So the only time they seek alternate source is if those water look like the one that I showed look like orange juice. And sometimes there are patients who, and I've showed you the pictures of that different types of technology. Sometimes you have water filters that just look overtly caked up with because they haven't been replaced. Those are the ones that are also contaminated. So then patients just look at it and go, ugh, I'll go and buy a bottle of water. But otherwise, it's perceived as safe as long as it's functional and it's from an improved source.
Thanks. This is really fascinating. I can envision, 60 different indicators that I might want to add on to a facility level assessment to track some of these things, which, in facilities that are already overburdened with just conducting a basic WaSH fit assessment is perhaps would be useful but isn't necessarily feasible. Do you see a way forward with some of this where we might integrate a reduced set of priority indicators into existing assessments to try to manage some of this, and what might that look like?
So take for instance the WaSH fit that you so highlighted. One of the things that WaSH fit also try to incorporate is what they call water safety planning. Sanitary inspection. But my sort of critique of that, if you look at the sanitary inspection, it's still drinking water based. So for my work, I sort of went by really quickly. I had to adapt a sanitary inspection that is for hospital water network. Because in those sanitary inspection that's currently for WaSH fit is only looking at the source. So there needs to be some adaptation. But we often say that sanitary inspection is not a replacement for water quality. But I think there are some parameters in the WaSH fit at the moment that talks about regular sanitary inspection, operations and maintenance. The more sort of system level indicators needs to be reported and actually actioned upon, because some things are so obvious. Please cover the tanks. Please fence it up. Please don't throw garbage around where the storage unit is. So these are all sort of barrier hazards that we can already start addressing. So we are currently working with UNICEF to start building this forward. How can I start developing, translating the sanitary inspection I developed for my work to, can that start being integrated into the WaSH fit hospitals to sort of push the envelope for sanitary inspection, and really now focusing, we've used this very much as a sensitization tool for the hospitals as well, to say this is why O&M is important. We need to start addressing those overt infrastructural defects. So.
Awesome. Let's give Leanne another round of applause.
Thank you.
And up next we have Shaan.
Hello everyone. Before starting, I would like to thank two incredible presenters for sharing their stories about some, I would say, some unheard aspects, some unheard dimensions of WaSH leading to the healthcare facilities and the link their work with the healthcare facilities. But now I would like to shift our focus from healthcare facilities to another important direction, to the schools, because schools can shape our future. And before starting my presentation, I would like to share with you why the work is important, why school is important, and why specifically schoolgirls are important. In the past few years, across different global platforms, there are increased discussions like how menstrual experiences of the girls at the schools affect their educational attainment and their academic performance. Because adolescent girls, they stay around 6 to 8 hours in the schools. So we need to understand whether providing access to the menstrual absorbents and the disposal bin, are these the only solution? What are the underlying factors that are affecting the adolescent girls, their menstrual experiences, and their education outcome ultimately? So in our work, we tried to explore the existing school-based menstrual hygiene interventions, specifically in the South Asia. And we also tried to explore how the intervention elements changed over time. What are the recent priorities? So that's the main objective of this systematic review and meta-analysis. So for our work, for this review, we explored 10 databases, and after removing the duplicates, we identified 163 papers for initial screening, and we included only those papers which described about school-based menstrual hygiene interventions targeting adolescent girls and reported at least one education outcome. It could be performance, it could be school absenteeism or school presence, anything. And after sorting papers based on our inclusion and exclusion criteria, we ended up with 5 papers. And we also reviewed the reference list of the systematic reviews to identify relevant papers. And in our next step, we conducted our meta-analysis. First, we extracted information. Specifically for our work, we focused on relative risk, the percentage, and we, after extracting information, we calculated the relative risk, which indicated when in presence of intervention, how the school absenteeism or other education outcome changed, the comparison between the intervention group versus the control group. And next, we used R for conducting our meta-analysis to determine the overall intervention impact. And now our final results from the review, we identified 5 studies that met our inclusion criteria, and these studies were based on Bangladesh, India, and Nepal. Unfortunately, we couldn't find any studies focusing on menstrual hygiene intervention based in Pakistan, Afghanistan, or Sri Lanka. However, cross-sectional studies are available, but there is no evidence how those girls are coping up with their menstrual experiences and how it's affecting their education outcome. And in our 5 studies, adolescent girls were included as the target population, and they were aged between 9 to 17 years, which corresponds to grade 2 to grade 10. And as you can see here, most of the studies were conducted between 2006 to 29, and we particularly digged into who delivered the intervention. You can see here before 2015, majority of the studies were, in the majority of the cases, the nurse and the female researchers were in the leading position who implemented the intervention in the schools. That means an outsider worked for implementing the intervention within the school community. But in recent times, you can see here, male and female teachers were engaged, which means there were increased prioritization for developing community ownership and how school teachers can be engaged to educate the girls about the menstrual hygiene. And also we can see in recent times there are focus on the policy changes. So the policy is one of the major driving force here. And we also explored the intervention elements. In early periods, intervention elements were focusing on mainly distribution of the menstrual absorbents and menstrual tracking calendars. But you can see here in the recent times after 2020, we have more other elements on board for our interventions. For example, improving the school facilities, storing menstrual absorbent at the schools, distribution of the storybooks, specifically engaging of the boys and engaging the whole school community in the form of the menstrual hygiene management committee. These factors were on board. And now let's look at the results. Initially, you can see here that distribution of the menstrual products and education, yeah, it worked. It reduced the school absenteeism. Oh, I forgot to mention, all the 5 papers measured school absenteeism at the education outcome. They didn't report any other measures. And you can see here when we have other elements on board, specifically improvement of the school infrastructure, menstrual hygiene management committee, and engaging boys for creating a supportive environment, the absenteeism, the reduction in the school absenteeism was drastic. It was significant. And this is our results from our systematic review. In our systematic review, we included only the non-randomized studies because we had only one RCT. We didn't include that in our meta-analysis. And you can see here, our intervention worked in both the models, random effect model and both the common effect model. It didn't cross 1. That means our interventions worked to decrease the school absenteeism. And intervention intensity across the 4 studies were also high. And before wrapping up my final remarks and some observations, in all these 5 studies, the authors, they measured school absenteeism based on girls' self-reporting. So there could be reporting bias. So these study findings should be interpreted with the cautions. And we will also recommend to consider other measures for tracking school absenteeism. For example, it could be daily diary, or it could be tracking installing fingerprint devices for tracking the girls, whether these girls or the students are present in the school or not. And in addition to school absenteeism, other measures, for example, class participation, academic concentration, or other academic performance in the examinations, these issues could be explored as well. And in all the 5 studies, they reported change in the school absenteeism. However, how this change occurred, or why did it happen, all these qualitative explorations were missing. So in our future programs and policies, we could focus on some qualitative exploration as well. And as I said earlier, engaging school boys created an open platform for discussing about menstrual hygiene and creating a supportive environment for the girls. And last but not the least, the 5 studies we focused on, they conducted the inline evaluation within the 6 months of intervention implementation. So they found drastic change. But what happened after that? We couldn't find any element on the sustainability of the intervention after the project period. So the future work could explore how these interventions, these programs could be sustained beyond the project period, and can also explore the appropriate financial planning. If there are some improvement in the school infrastructure, how will these structures will be maintained after the intervention, the cost recovery strategies, and also who will monitor whether these intervention materials are functional or not. These aspects could be explored in our future research. And these are my references. And before wrapping up, I would like to thank my professor, Dr. Hong. Without her guidance, this study wouldn't have been possible. Thank you.
Thank you very much. I was curious, did you just look at absenteeism as the outcome because of the narrowing of papers that could be included, or were there other outcomes that you could include in this? I'm just curious about other outcomes.
Okay, so this is a class project for my PhD, and we purposively picked the South Asian region because we wanted to narrow it down so that I can accomplish the whole systematic review and meta-analysis within 1 semester. Okay, but about the intervention and the outcome, education outcome, we were open. Like as I said, in South Asia, they reported only school absenteeism. They didn't explore other aspects, like academic concentration, or we know sometimes when in case of sudden menstruation specifically, when there is no facilities available in the school, the girls, they leave the school in between the classes. So that's another kind of absenteeism as well. But those, I would say, micro points were not explored in case of South Asia.
Thank you so much for your presentation. Very interesting. My name is Maraya from UNICEF. I'm just wondering, maybe could you explain a little further on why you ended up with only 5 papers? Because you started with 160 or more after you removed the duplicate. So why did you end up with only 5? Because I'm just wondering, you end with recommendations of how you could improve future research. Maybe we don't have a lot of good studies to begin with. You only looked at 5, so could we? What can we do to improve the quality of studies on MHH and use that for our policy planning?
Yeah, I guess I have excluded 6 or 7 additional papers because those studies also, those were menstrual hygiene interventions, reported education outcomes, but those were conducted outside of Southeast Asia. For example, in African countries, there are at least 5 more papers based on African countries. So if we want to improve this study, I will have to expand its scope, and just the Southeast Asia, it is just putting a bar here, I would say. So that's one major limitation. So I need to remove that regional bar. And I guess I forgot your second part. You had a second question.
No, that's fine. It's okay.
Hi, thank you very much for the presentation. I'm Marissa from the Water Research Institute in Switzerland, Java. I was wondering if you could expand a little bit on the interventions themselves. So one of them I saw it was about disposal facilities. So I feel like a lot was on education, with the MHM community, for example. But were there also infrastructure changes that were made? And maybe you can explain.
Okay, so about the infrastructural change, for this study, Shaan et al., this study was focused on the major policy reform in Bangladesh. So in Bangladesh, in many schools, there are no disposal facility. a simple disposal bin where the adolescent girls can discard their used menstrual pads. That's missing. So the policy is encouraging the schools to keep at least one disposal bin in the toilet, and also for the gender sensitive needs, to address the gender sensitive needs of the girls. And about the education session, the whole menstrual hygiene concept was missing in the national curriculum. So the topic was included in the main textbooks so that boys and girls, everyone can learn about menstrual hygiene and the changes related to the puberty. And about these two studies, it's almost the same. The disposal facility was installed. The female teachers were leading education session for the adolescent girls, and the male teachers, they were in the leading position for the boys, for sensitizing the boys. And that MHM corner means storing sanitary pads in the schools so that in case of any emergency or in case of sudden menstruation, the school can help the adolescent girls and she will not need to leave the school. And about the storybooks, we found it only one study conducted in Bangladesh. Under an intervention, 3 storybooks were delivered to the students, both boys and girls. One is on puberty, specific in general puberty. One is focusing on menstruation, a kind of comic storybooks. It's not our conventional or traditional books. And the third one is related on puberty and related changes among the boys. So it's a way of sensitizing both boys and girls when they will be able to know about each other changes. And the locked question answer box, this is an interesting point, I would say. In all the classrooms, the implementers or the researchers, they put a locked question answer box. If a student has any kind of question related to the puberty or menstruation, he or she can write anonymous questions and drop it into the question box. And after 1 week that it's locked, the teacher will have the key, and after 1 week the teacher will open up the box and read the questions and give the answers. The idea was to deliver correct information to the students and from someone who can trust, the teacher. And the MHM committee in both these two interventions, students, parents at association, some parent representative and the teachers, they formed a committee and they used to meet once or twice in a month and discuss about the overall menstrual hygiene management scenario in the schools. And as I said, engaging boys means educating the boys about the menstrual hygiene related needs so that they are sensitized and they will not tease the other girl students about their menstrual hygiene.
Could you explain, just on your meta-analysis chart, I was just having a quick look, the number of samples in the end, pool samples, because I was trying to see how many, what would a sample size for each of the study, what interventions were you able to? Intervention,
as far as I can remember, Jahan et al., they have around more than 5,000 samples. 5,000 adolescent girls in total. I guess they covered around 300 schools. And for the other 3 studies, it was very limited. It was ranged between, I would say, 200 to around 600 students.
Okay, so the sample numbers of students.
Yeah. And they have covered between, I believe, 2 to 6 schools in between.
Actually, just as a follow-on point, I'm wondering whether those studies came about after the Bangladesh introduced the national strategy for menstrual hygiene in 2021.
Yeah. That's true.
All right, let's give all our presenters one more round of applause.
Trying to work out what was the outcome of the national strategy for menstrual hygiene. I went to the launch when it just started, and I didn't follow up for that. But that's the poster was what the last sort of public access for now. Hopefully I should be able to sort of patch it together so it can take consistency of strategy and support. So I'm under time pressure to do this. Oh, my boss is here. Shit.
He was under time pressure to do this.
And then, yeah, so hopefully we're looking to sort of disseminate widely. But a lot of the work has been slow because currently I feel an onus to sort of disseminate back to facilities, and it's been really much a very sensitization process. And yeah, coming back on what you're saying, so those are the things that I've been sort of reflecting how can we capture improvement, but it's really systemic strengthening to address. But I'm so excited because the work's been galvanized. That's how I ended up doing the strategy now. So I'm sort of using this to sensitize the government that we need to make change, and that we are now doing a system strengthening approach, rewriting the national strategy. So yeah, so hopefully, definitely anyone's sort of input on how we can sort of try and tap and measure.
We do always laugh when we see all those green ticks for the Bangladesh.
Okay, I just love it. I'll tell you about the 8 practical steps.
Well, I see our PhD student Lucy on the side here, who's working on benefits and impacts of WaSH and healthcare capabilities, who I imagine has many follow-up questions.
Yeah, no, I was going to ask probably what your like next steps were, but it sounds like you're working on incorporating this into
Yeah, so the work has been sensitized. Yeah, so we're now working with, so FCDO is supporting us to a technical consultancy to redevelop the national strategy. So it's all like sort of the Overton window. So the first strategy ended last year. So the data all came through, then we used this as a basis that we really need to make change. It also helped that we actually haven't made any progress in WaSH, so that we're sort of static. So this is now sort of much more system level into approach and strategy rewriting.
Remind me, how many hospitals were in your sample?
So we currently have, so there's 20 facilities with 7 of those had 3 rounds of seasonal sampling. I have another 32 now, and I'll be expanding it to 181 facilities next year. So
Just hospitals? Okay.
But we've got 32 that was just completed into that I can plug in.
How nationally representative will that eventually